Hi, everybody. It's AJ Heitman, the editor emeritus of GEMS, and welcome to the EMS Today show. A really innovative way that we're trying to get some messages across, talk to some leaders in the field, and obviously right now with the pandemic going on, we're trying to focus on a lot of people that have some things that are really underway that can help us out. So with me right now is a member of the GEMS editorial board. He's assistant vice president for the Center of Emergency Medical Services at Northwell Health System in New York City and Long Island. It's Jonathon Washko. You're all familiar with John. And John, we're really in an apocalyptic time, and I'm hearing your name mentioned a lot by Governor Cuomo. The hospital system is huge, the largest in New York State, and obviously they're relying on Northwell for a lot of things, but your can of worms is really EMS, and you have some innovations to talk to us about. Welcome.
Yeah, thank you, AJ. It's good to see you. It's good to be able to work a little bit from home. Home today, just trying to do a little bit of personal recovery. There's a lot going on. Most of us are working, haven't had a day off in 3 weeks, doing 15, 16-hour days. Just trying to keep up with just the tsunami, as there's no other way to describe it, in terms of all the various things that are happening simultaneously as this event unfolds. I've been getting, I think I shared with you, I've been getting a lot of phone calls from many people with well wishes, but also asking for advice. So, I'm working to try to get this out. A lot of people ask, what can you do for New York? What can you do for us? And obviously the governor's put his request out for resources. But one of the things that I ask is that what you can do best for us is listen to the advice and implement it. That's the best thing you can do. So I kind of want to go down a list, if that's okay with you, to, kind of share some of the things we've learned and some of the things we did, beforehand. To really kind of prepare for this.
Sure. And well, for some of our listeners who really don't know you or your system, you are the second largest responding system in the 911 network in New York City, in addition to all your other responsibilities for the Northwell network. So you are always on a daily basis very busy in New York City. So have you had to divert additional resources to New York City?
Yeah, absolutely. We have additional resources. We're helping them in many ways. Some of which we can talk about and some of which we can't, but definitely more resources in terms of ambulances doing everything we can to try to, within our hospitals, get the ambulances turned around quickly. There's been all kinds of issues, as you can imagine. The fire department in New York, I believe's normal call volume on a daily basis is around 4,000 calls. I believe they hit 7,000 the other day. We know that obviously that's a very difficult thing to keep up with, as the volume continues to grow, it's really kind of a war, a struggle of supply and demand, and trying our best as this, just this tsunami of demand hits us to, try to do our best to keep up with it.
And we have this other veil of PPE, and I know the fire union kind of lobbied that the engines are not responding on severe respiratory distress calls because of exposure, but those are the exact calls where you need extra people to get people out to the ambulance. So that has to be another obstacle right here. Everybody's nervous, obviously, and EMS is telling me the police really don't want to go in, the fire department really doesn't want to go in, and the EMS folks are the ones left to really be on the front lines.
Yeah, unfortunately, there's a lot of truth to those stories. I'm not here to criticize anybody and get into the politics of it. But yes, I mean, for the most part, the EMS providers are working tirelessly under very stressful conditions, sometimes with help, sometimes without help. Honestly, AJ, it's just a real struggle. I think we're very well ahead of the power curve in terms of trying to do our best to take care of our people and make sure we have the PPE for our staff and put our staff safety actually as number one above everything else. And that's what you have to do in these situations, which unfortunately means sometimes you have to put them over patient care. But if our staff aren't with us and they don't feel safe, then they're not going to be able to provide care at all. And so we have to prioritize.
So as we enter April, you've launched a really innovative program that I understand is really was in the planning for a long time and was not really scheduled for another year. And your group miraculously put it into operation now. So why don't you tell us about that? Because I think that's really what everybody wants to hear.
Yeah, absolutely. So, under the ET3 model, we've been anticipating and in participation of that, and we were, awarded the ability to participate in that program. And, as part of the design, about a year from now, we anticipated that they were going to be doing what's called a NOFO grant for, nurse call triage and giving people capital to put up nurse call triage systems for those that were participating in ET3. And then, we really didn't know where it was going to go from there, but I think many of us assumed there would be some form of sustainability funding once those systems were propped up. So we've, been preparing for that. We've actually been using nurse call triage in our 911 center since 2013, but we don't use it for 911 de-escalation. We use it for population health management. So we had a very different workflow. So, our intent was to eventually turn on, ECNS for our emergency calls, as well as, do treatment in place and alternative destinations. And, I believe, hopefully everyone saw the other day that CMS has approved alternative destinations under the COVID pandemic. They've not approved treat in place, although I think some are interpreting the ability to transport home as that. I'm not interpreting that because if you really read into it, they're trying to prop up the tools necessary to what they're calling hospitals without walls, which is basically people, being able to go to these alternative care sites that you hear being, deployed in New York, like the Comfort and the Javits Center, but also be able to have people go home and respite there and seek some form of care at home, whether that be through telemedicine or other types of visits, hopefully community paramedic. That'll be our next thing, is to kind of try to expand out into that realm. But more importantly, was the concept of telemedicine. And one thing we advocated for and lobbied actually very hard. We went to Sam and I directly. We actually got a chance to go to the White House to talk about this, was the ability testing center. And this was all pre-pandemic. And as well as allowed non-911, but certified, I'd say, emergency clinical coordination centers such as ours to be able to participate in the ET3 model and the treat in place model, and we've been pushing really hard for that, and we're still not there. There's still some barriers, but with the recent waiver by CMS for telemedicine, it was an opportunity for us to really kind of step back and say, wow, we could take what we were going to do with ET3 and take it this next step farther, which is to do telemedicine without even having an ambulance respond. ET3 requires you to have an ambulance on scene in order to do the telemedicine visit. And obviously you also get reimbursed for a base rate for that treat in place intervention. But they weren't willing to pay for any form of telemedicine. And likely there was a lot of opposition to that for a lot of reasons you can imagine, politically and financially. But the COVID crisis, changes things, as they say. Necessity is the mother of invention, but also drives acceptance of the previously unacceptable, is something I always like to say. And obviously, we have a major necessity situation here. So, the regulations are getting pulled out. New York State's been amazing, and Ryan Greenberg and the State Office of EMS, I got to really say thank you to him and them for just pulling out a lot of the stops to help us in this time of need. The governor's office working very closely with us, obviously, in our health system and our CEO to really try to work through some of these issues and problems. Just a lot of amazing work going on. So we work tirelessly. We have the team I have here at Northwell is just absolutely amazing. Our field staff are working hard every day. They're putting it out on the front line. Our supervisors, our managers, everyone, our training people, our quality people, everybody's kind of on the road at this point. And we have a lot of support behind us with our logistics teams. Our billers are working from home so that we can continue to keep the revenue moving forward, which is something that's a whole other issue we should probably talk about. How do you the financial sustainability issues of this? But really, we went on a sprint, and we week and a half ago, we're asked to take on this challenge, and it's been a tireless effort by probably 70, 80, 90 people across many different departments within our organization, working in unison, countless hours, hundreds and hundreds of labor hours to get all the right things in place for us to actually be able to do this, including the ability to actually bill for these services, because we have to have some form of sustainability, and hopefully the disaster payments will help with some of this, but we really don't know. So we literally got the technology in place. We had to build technology that didn't exist for us to be able to do this, because there's a lot more to it than just a FaceTime call, unfortunately, to really make this happen and do it reliably. We essentially turned our EMS service, the best way to describe it is, into a virtual physician practice. We got our own billing system. We got our own EHR system that's integrated. It's all based on provider-based billing, a Part A versus Part B supplier billing. And I've been taking a crash course on, that, because I had no idea how that world worked. Yeah, as well as, like I said, build workflows. We had training to do. We had to get people online from a capacity standpoint to take on this mission, both on the nursing side, on the paramedic and EMD side, on the registrar side, on the physician side. And we've been very fortunate. We've been working very closely with our physician leadership and with the emergency medicine service line to help get us physicians for this, as well as our urgent care centers, who are also doing telehealth, and we're coordinating with them, as well as face-to-face visits to be able to book appointments for patients, via 911. So literally, you can call 911 and get an urgent care booked for you. You can call 911 and get it scheduled telemedicine visit. You can call 911 and get an immediate on-demand telehealth visit by an emergency physician. And it's all based on a triage system that we have. We're also introducing, we obviously have nurse advice as part of ECNS, and we've introduced during the pandemic paramedic level advice. So we're actually using paramedics in the call center, just in anticipation of the call volume, for super low acuity patients, to basically go to CDC guideline kind of review of patients calling and seeking advice.
So walk us through how this is working, because I'm a little confused about how your 911 calls come in. Does this happen when they're transferred to you from the city's 911 system as well?
Yes, I mean we get a 911 handoff from various different agencies that we work with, and from that, then we run it through a workflow. We use the Clausen system. We're an ACE accredited center. We use the PDS system with the Omega protocol set. That allows us to do a frontline triage of these patients. We're using Pandemic Card 36, which is a special card that's used only in emerging diseases or pandemics, which allow us to do a triage, and start to kind of navigate patients into the appropriate types of care, sometimes without having to send an ambulance. And so it's a very, I'd say, a rather sophisticated system. The best way to describe it is kind of like a sand filter, where you have various courses of sand that you run water through in order to kind of filter out impurities. We do the same thing, but the layers of sand granularity are different types of care that we provide. It's the best way to describe it. So obviously the deltas and the echoes, Charlies and Bravos all go get an ambulance right now. Alphas and Omegas go through various types of ECNS, and then the ECNS system navigates the patient to what's called the recommended care level, or the appropriate care level, which really is broken down into four it's a magic quadrant, vertical and horizontal axis, which is can the patient get face-to-face care? Can they get remote care? And then is that care needed immediately or delayed? And so based on the landing within those quadrants, we have various response plans associated with those. And that's where the telemedicine visits come in, scheduled, unscheduled, paramedic advice comes in, nurse advice. Go Health or our urgent care referrals to a PCP and getting a regular physician appointment. We have a variety of endpoints that we can navigate patients to that we've
Could
been able to prop up very quickly.
you give us a snippet of each of those sections, how each of those works? If I was navigated as a piece of sand to that level of telemedicine, whether it be paramedic or you have physicians as well, right?
Yes. So, let's say, for example, you have a self-care. So that's, delayed remote and it's kind of its own standalone. And so self-care has been broken down into typical under ECNS as nurse advice self-care. We've had to, again, under emergency rule and in discussions and working very closely with the International Academy of Emergency Dispatch, again, who, by the way, also have been amazing partners in responding to us and giving us everything we've asked for very quickly to help us during this crisis. So I got to really give them a shout out as well.
Did they revise Card 36 for this?
They're continuing to revise Card 36, as well as they're working with agencies. I know they're working with New Orleans, who's heavily hit with this. They're working with us to again make sure that we can do everything we can with the resources we have to try to maximize the benefit to our patients. So that's self-care. Kind of going back to that landing area. Again, can be nurse advice or paramedic advice. And so, for example, if somebody has flu-like symptoms only and there's no other issues, there's no comorbidities, they're considered low risk, that'll land in paramedic advice. And we actually went to the CDC website and grabbed all of the self-care instructions off of that and protocolized it into kind of a navigation system for our call takers, so that way they can actually kind of read through it, as well as we created a system that allows us to email those instructions or text those instructions to a patient. Again, a lot of work here. We really created a comprehensive, robust system.
And who gets sent over to the physician?
So the physician would be like a remote immediate type situation. So again, those four quadrants, you land into a remote visit immediate situation. These right now are of higher acuity than normally would because of the pandemic. So for example, our 36 Charlies are going to telemedicine, are going to ECNS first. And then if they land in this one quadrant of immediate remote care, that's when we get our physicians on the line for immediate telemedicine visit. If they can do a delayed face-to-face situation, then that's where we do scheduled urgent care, and face-to-face can be a telehealth visit through urgent care versus or going to the brick and mortar place. So like I said, it's all dependent on where they land in each of those four quadrants, and then it's up to the way it works is actually it's a nursing, the ECNS system helps the nurse with protocols, but they can also use nursing judgment once they get to an RCL of which locus of care to initiate for that patient.
Now, is this a physician who's at a console, or is it pick a physician from throughout your system?
So actually, it's a physician in our 911 center. It's something we've actually been working on because we do many things at our 911 center. Our medical communication center is really a better way to put it. We also manage every single transfer within the health system, inbound and outbound, and not just for ambulance transport, but also for the clinical handoffs associated with moving a patient to higher levels of care, tertiary care, quaternary care, as well as back transfer, lateral transfer, which is happening. We didn't have a lot of that in the past, and that's gone through the roof in order to load balance the hospitals to make sure we can match the demand for ICU care, for example, to the ICU beds, med surge care, and so on. So we actually have physicians as part of that program. In between doing the work of the things that they have to help manage on the lateral transfer side, they're doing this telemedicine mission for us as a secondary mission right now.
And what if I'm sent over for a scheduled urgent care visit? Who takes that call and who talks me through that?
Yep. So either a couple of our omegas or alphas will land onto that. So the EMD actually can do that, and we have a web page that we can go to that we can book these for the individual on the phone. We can book face-to-face visits, and we can book out scheduled telehealth visits. The nurses can do the same. So the nurses can go and book those appointments for our patients in either of those delivery methods.
Because of fear for transportation and travel, are a lot of people relying on the actual video telehealth or cell phone telehealth?
Absolutely. So part of the waiver is, you don't have to use HIPAA compliant technology. We actually do have HIPAA compliant technology, and as part of our health system and their own telehealth program that we do for in other programs. We again were in preparing ourselves for this for Treat in Place, and this was the platform we were going to use. We did a rapid deploy on it, and now have it in the hands of every one of our medics. But we also are able to, when a patient calls, we can send them a link and immediately open up a telemedicine visit with the physician and the patient. And then we have the fallback systems of FaceTime. And we're looking for another fallback system for Android. But I also know that there's a lot of EMS tools. I'm actually having discussions with a lot of different of the Pulseras and the general devices of the world, because they rapidly developed the capability to do the exact same thing. It's an invite in kind of telemedicine model where you can send a link to a patient and actually initiate a video visit. There's lots of options out there. There are some that are EMS centric. There are some that are obviously, like, you can go online. Zoom, this technology you and I are using right now, is actually currently waived for use for telemedicine, as is FaceTime, as is Skype, as is WebEx, when you couldn't use those in the past. So that's a temporary authorization from CMS. We'll see where it goes from there.
And if I wanted to go to an urgent care center, are they only Northwell urgent care centers, or do you have relationships with others?
So right now, this is Northwell only. We have about 50 different urgent cares. Part of ET3 and part of our agreement with ET3 was to use all alternative destinations. We were fortunate enough, and along with our partners at or our other health system at Mount Sinai, and others that are working on this as well, to put up these kinds of systems, because the city's intent is to leverage everybody and get everybody to help. And like I said, we serve lots of different communities, so across Long Island and within the city.
So how do you get them from their home to that urgent care center? Do you arrange transportation?
So we're not there yet. I can tell you that, frustratingly enough, but I can also understand it. Essentially, the ride share programs want nothing to do with this at this point, because of, quite honestly, the legal ramifications
Right.
of this. If someone like an Uber or Lyft driver would get COVID, who takes on that burden? And so we've actually been talking very closely with folks from those groups, within the New York market, to see what our options are. And as of right now, that's not likely going to be an option. So, we haven't rolled out the alternative transportation methodologies yet. It's been part of the ask that we're working on, but we're not quite there yet. And it's going to take time. I mean, the way we put this together and did it in a week and a half is, I've got a software engineering background. Todd Stout and I started First Watch together many years ago now. And so I'm using a software engineering approach that we call MVP, or minimally viable product, which then allows us to initiate, and then we do what's called iteration. So we literally, feature by feature, function by function, we eat the elephant one piece at a time and grow the system. And then we have our engineering methodology is designed for change. So we're literally, as we learn lessons, as we get new ideas, as we need to add new feature sets, we're able to, using the iterative process, add those in, and further, develop the systems that we need to be able to manage this and improve throughput, ensure safety, ensure quality, ensure patient choice and satisfaction, as well as provider safety, and so on.
I guess it's a two-sided question. Can or are you transporting patients from home to urgent care centers yet?
So we have the authorization to do so. I can tell you that across the entire region, all of the urgent cares are at capacity because many of them are doing testing. So that's the thing you have to understand is when the hospitals are busy in a pandemic, everybody's busy in a pandemic or they're closed. So, for example, our hospital physician practices are doing everything through as much as possible through telemedicine. Like I said, the capacity of our Go Healths, I know are definitely full, and the clinicians there are again another amazing group of individuals, and are doing everything in their power. To provide services as best as they can. Obviously, there's a lot of need for clinicians on the front line. Some of our clinicians, unfortunately, are exposed and sick. So, this is a very difficult juggling act of resources and matching supply and demand, and trying to do that in a way that you can try to service everybody. And you know, it's a very difficult thing to do. As of right now, I wouldn't say people are being denied care or rationed care, but it's definitely care is being delayed. And if we're unable to keep up with capacity, then the picture might change. Everything is being done. All the stops are being pulled out. At our largest quaternary facility, they literally pulled out every chair, mounted chair in a huge auditorium, and are building ICU beds in a former auditorium that was like for presentations. Unbelievable. Just the things that are being done right now to
So
to do to match this demand.
who's screening the calls, and what types of patients are you taking to the tent hospitals in the park and to the hospital ship?
Yeah, so we're not there yet. Just like we're having to MVP and iterate, they're having to do the same. So I believe the comfort comes turnkey. So they're accepting non-COVID patients, and I believe they can accept up to pretty moderate acuity people, but they have to be clean. The Javits Center right now is only low acuity. And the messaging has been a little mixed whether that's clean or dirty. Originally, I think it was clean, but now I'm hearing they might accept dirty, meaning they have COVID or positive or negative. That's the kind of term they're using. I apologize. It's a little derogatory. It doesn't sound very nice, but that's the terminology. I should probably use COVID positive or COVID negative. But those systems are just coming online. They need time. Having beds is great and having ventilators is great, but we got to have the staff. We have to have the medical equipment. We have to have the medical supplies, all the things that go with expanding hospital capacity and logistics of that and the logistical nightmares of that. And just imagine, AJ, to just
Oh, I
what's
can't.
involved what's involved with all of that to open, especially when you're opening up capacity at high schools and colleges, which we're doing college dormitories, in college campuses so that the stadiums can be used, the Arthur Ashe Center. I mean, just again, the sheer logistics to be able to,
I'm trying to wrap my head around 1,000-bed hospital ship, and are they there? Are they accepting patients, and can they accept?
Yes, they started receiving patients, I believe, yesterday. As of right now, they're not accepting 911. They're only accepting lateral decompression transfers, from what I understand. Meaning, they're trying to decompress the hospitals by moving, patients from the hospital into the ship. I believe the intent is, and I'm not at that level in the planning, so I don't want to misspeak. But I understand eventually. I think there'll be more full offering hospitals at some point as they get up to speed and as they ramp.
And then the tent in Central Park, is that even though they have vents, somebody has to decide who's going to go in there, and you got to go clean versus dirty.
Yeah, I believe that's going to be, my understanding is that's a dirty facility for COVID positives on vents, obviously. And so that capacity is absolutely going to be needed. Just the sheer number of ICU patients we're seeing is, unbelievable. It's one of the things I started actually quickly looking at some of the statistics, and I haven't had the chance to really go through, true diehard statistical analysis, but I can tell you we've had more cardiac arrests in the past week and a half than we would typically have in over a month. It's ramped up. There's just this huge acceleration curve when you look at the data of cardiac arrest, respiratory calls, same thing. And we're experiencing what a lot of other providers have experienced. I'm getting a lot of phone calls. Hey, our volume's down by 50%. This is a joke. Are you kidding me? And I'm like, guys, that's the calm before the storm. It's coming. And like I said, it's like I use the analogy of a tsunami and the stages of a tsunami. So when a tsunami happens, right? It usually happens remotely. The earthquake happens under the seabed, and nobody knows it's going, or it's in a different part of the world that you don't see it coming. And then all of a sudden, the water recedes, and you kind of sit there, and that's like a lot of people are in that water receding time right now. Where the volume's going down and it doesn't seem like anything's going to happen. And then bam, I mean, the first wave comes in and then the second wave comes in and drives everything on shore. And I mean, it's the best analogy. And we've actually seen waves like that coming in terms of volume. We had this huge spike and then it dropped for a little bit and then another spike. And that's where we are right now. We're in the second wave
Well, let's
of call volume.
Talk about the patients, because the people that are watching this show need to understand what I understand, and that is that this is very different from just pneumonia. When you get somebody who's got the virus, who has comorbidity factors or is obese, they go south really quick. They need not just intubation, but a vent. And if they're on a vent, they probably aren't going to survive. Am I off base?
You're absolutely dead on point. And it's been interesting because I think people are actually listening to the advice of the CDC, which is to stay home, even if you're sick, and you only go call 911 when you go into severe respiratory distress. And that's what we're responding to is severe respiratory distress. We get on scene. People are sat in the 80s, low 90s. This is ages everywhere. Obviously, it hits the elderly more. Looking at our stats, things like that, but we're seeing 50-year-olds, 40-year-olds. And when it hits fast and it hits hard. And it's usually after a week and a half of being at home. For those, those 3 or 4% that can really, excuse me, I think it's more like 20% that can get really sick from this out of the 80. And then obviously out of those 20%, there's a mortality rate within that. But we're seeing very sick patients. I've heard, I listen to the radio every day. I'm listening to radio reports. The number of emergency transports back to the hospital is through the roof. Unfortunately, like I said, the number of cardiac arrests are through the roof as well, which is very, very difficult for us to hear and also have to deal with for the health and well-being of our staff.
Now, the city put out a directive that codes are going to be terminated on scene. Does that apply to you as a 911 responder? If you can't get them back on the scene, you pronounce them?
It does. So we're just rolling that protocol out as we speak. We actually went to a non-intubation protocol about a week ago, as well as a non-aerosolizing procedure. So we were able to find, for the Venturi mask, or the masks where you don't have to aerosolize things in order to give a treatment. We're trying to limit the use of CPAP. We're not intubating at all. We're only using a rescue airway at this point. Again, trying to reduce the exposure, to our patients. And as of right now, within a few days, we will not be transporting patients with CPR in progress. We will only transport if we have ROSC.
Okay, so there's a logistical issue that I think people are going to want to hear about. If I'm running a code and I terminate it, I got to run and go on another call. Who stays with the deceased, or what happens to the deceased?
That's really going to be up to local protocol. For us, we have a protocol with the law enforcement and usually, an undertaker. I can tell you that they're all overwhelmed. I can't speak firsthand, but I think you can try to figure out what that means. It means people will be alone until, the services can come. Because obviously we have to continue to respond. We do our best, to be with our patients. I can tell you, one of the other things, the capacity is so high, the amount of time it takes to don and doff PPE. to go into the home, and then when we come out, and then whoever ends up driving the ambulance has to doff and then don again. So it's those challenges take time. And so the task times are through the roof. The wall times at the hospitals for offload are through the roof. We're also having to transport, for our load balancing trips that we're doing and our lateral transfers, very, very far away, literally out to the Hamptons from the city, in order to redistribute patients across Long Island as well as up into Westchester, from the epicenter to the epicenter, which is Queens. And so all the Queens hospitals, not just Elmhurst, but everybody is basically in the same boat as Elmhurst. It's a war zone. I'm hearing it's as bad, if not worse, in Italy in some of those facilities, and we're doing everything we can to help them out.
Do you leave them at the door, as some crews have said, or do you take them inside and have to wait for an exchange?
We've not left them at the door yet. I've not heard that one, and that would not be our protocol.
Because you want to do a face-to-face and transfer care and all those things as you do normally.
Correct. And again, I think if there's walking wounded, it's pretty much like any process, right? You take them to the waiting room. I'm sure those types of things are happening, but the people we're transporting, at least on Long Island, that I have direct access over, are very sick, need oxygen, need support, supportive measures. We're not going to just leave somebody like that waiting for care. That's as of right now, we're not at that point anyway.
Well, let's talk about my peeps. How are your people doing? This is a very, very difficult, this is worse than a battlefield. This is, an invisible death, as I said. So you can't trust any patient, really. You just have to be suspicious. And how are you doing? How many have you lost to sickness? And what are you doing that you really think is novel or really a message you want to pass along to other systems?
Yeah. So first off, again, our people are doing an absolutely amazing job. The workforce is united. The workforce is there for our patients. As our slogan is, "We're made for this," and all of us are made for this. We've had nobody abandon their post. We do have some that are COVID positive, but not many. And I think that's because we took this seriously very early on. We mask mandated everybody very early on before anybody else did. And I took a lot of slack for this, AJ, a lot, because people were like, "Oh, you're overreacting, you're doomsday, or you're a nut job."
That's what leaders do, John.
That's what leaders do. Yeah. So call me a nut job for protecting my people. But we went on to a mask mandate well before this all happened in our 911 center. We were on a mask mandate 2.5 weeks ago.
Amazing.
In the field, we were on a mask mandate 2.5 weeks ago. We were medical screening. We closed down, started with in the 911 center. We basically made ingress and egress through only one point. We started temperature screening. We EIDS screened everyone. And that was important because the quarantine system and the quarantine process changes. So the initial guidance is 14 days if there's exposure, and then anybody around them also had quarantine. So the minute I heard that, imagine someone coming in sick in your 911 center, and making everyone sick, and then having to decontaminate that facility. I mean, just it would be an absolute train wreck. So
your medical screening before they come in the door?
Absolutely. And we started that in our 911 center. Now we're doing that in the field as well. So that's important to make sure people are healthy. Like I said, the mask mandate, I think, has been one of the bigger things we've done, but also making sure that our people have the PPE that's necessary. We actually, we're very much communicating with our staff using Workplace, which is a Facebook product for real-time communication. We're doing video chats with them on a frequent basis. Our medical director is doing video chats, Q&As, answering all the questions, trying to get the FAQs up. The policy, the PPE policy is changing so quickly. It's very frustrating and difficult to keep up with. So we're using that tool to help us, communicate with staff. We're also using neural communication tools like Microsoft Teams, for our leadership team and our 911 center, our communication center, for all of these different projects, as well as the hospitals and the physicians. Being able to literally use like a Slack chat or a Teams chat, as well as Teams, channels, to be able to communicate mass instantaneously across very diverse and places where we would have had to page or use a phone or phone call or something like that, or a fax machine. In the past, we're able to basically instantly communicate with people. So that's also been a significant tool that we've used in the non-field side. We will be instituting the telemedicine piece in the field, like within a few weeks. We're not there yet, and as well as our community paramedic program has been working strong because the population we serve is the elderly, frail. In our house calls program that we've been doing since 2013. And we've been using, the treat in place model with telemedicine for a long time. And this population is having a lot of challenges. And so we're doing everything we can to try to help that population.
So I know you, and I know about you and stockpiles, but how did you get us so many masks to be able to do this without everybody else being so diminished with their masks?
We had these on stock. We weren't stockpiling beforehand. I mean, our health system, you got to remember the size of our organization, AJ. So, we actually have our own distribution center, like an Amazon warehouse, and it actually operates just like an Amazon warehouse to support all 23 of our hospitals, as well as all the physician practices, as well as us. So, we're very fortunate. And, I think we had our own, as I understand, we had our own stockpiles. Not so much stockpiles, but we have our own resources that we've always kept on hand even before the pandemic, and I'm sure we ordered beforehand as we were watching what was going on in China and things like that. Not so much to hoard, but to be able to just have enough PPE to make sure we're taking care of our folks. I was very fortunate to have had a briefing during an NAEMT board meeting. About a month and a half, 2 months ago. This was, I think it was in late January or early February, where they were talking about some of the things in the forecast coming out of China and what some of the American minds were saying, but weren't quite public yet. And one of the things they said is you need to prepare to take care of your people. Because if you don't, you'll have abandonment rates, right? People won't come. They'll abandon the job if they don't feel safe. And I took that very, very seriously. And that's, like I said, been our number one priority is provider safety. And then obviously the very, very close second behind that is the patient care piece.
I've been getting calls like you have from all over the country, and they're asking about stockpile and where we're going to do this. And I've referred people, you just have to get imaginative about who has N95 masks. And where I was from in Pennsylvania, in the cement industry, all of the workers have N95 masks, and they're shut down right now. So their mask stockpiles are there. Tattoo parlors, hairdressers, nail salons, all of those people have N95s. All of our Harbor Freights have taken all of their gloves and masks and made them available for medical purposes. So go out there to your industries. There are people, if they're dealing around dust, they're dealing around N95 masks.
Yeah, absolutely. And we've had, I'm sure you've seen these stories, or you may have had even these stories on your own where, people are just bringing whatever they have, whether it be small businesses, individuals, bringing, their masks and their supplies to the hospitals. We have people making masks. We had someone bring a large number of homemade masks that were sewn, lovingly by a group of individuals to our facility. And I know they've been all over. And so, those things have been very helpful, especially because for the most part, we're on procedural mandate. And then the N95s are only for very specific things right now, just trying to conserve. And I wouldn't call it rationing. I call it judicious use, because what happens if we have none, right? So I know people are upset that they're having to use a mask maybe longer than they'd like, but what's the alternative?
I had somebody yesterday tell me, a physician, that the material that's used in the OR to place the sterile objects on is a good material that can be used for bandanas during this time. And one sterile tray cover can make 3 or 4 bandanas. So it's really amazing what people are doing during this time. So what other things before we close, John? What key points do you want to give to other managers of systems? Because we know it's coming. I mean, my prediction is New Orleans should have a couple of cruise ships there, like they did for Super Bowl, and convert those cruise ships into hospitals. And I think that'll probably happen. But you know, after Katrina, they lost a big hospital and never replaced it. So they're really going to be hurting in a big time way. Philadelphia's hurting. Everybody's
Right.
hurting, but they're focusing on New York for some reason. And I think maybe that's a mistake on the media's part because the rest of the country's hurting as well.
Yeah, I can't disagree with that, AJ. I mean, let me kind of go through the list that I've prepared here. So, as I mentioned before, take this seriously. Do not think you're immune to this. I'm getting calls from chiefs that are like, "Really, you did that? That seems a little extreme." You got to go extreme. You've got to protect your people. You've got to take this seriously. You know, one of the things we didn't talk about, but we decompressed our building as much as we could, and figured out how to find about 50 laptops, and you know, got all of our billers out of the room, out of the office, got you know, many of our middle management and leadership that aren't field force, you know, out of the building, working remote. Like I said, I'm able to work remote some, just purely to decompress the room in the building, and the people density of the building. We already talked about the screening. Obviously, you need to make sure your policies and procedures are keeping up with the constantly changing isolation guidelines as well as PPE guidelines. This was another interesting thing, AJ. You can't rely on mutual aid. You are on your own. You
Yeah.
are on your own. This is happening in more than one place. There is no mutual aid. So while people are coming and helping us, which is greatly, you know, greatly appreciated, and FEMA came in, I don't, you know, that hopefully this, if it's not going to happen everywhere at the same time, because you're on your own. You know, and it's really a Katrina. Think of a Katrina lasting 2 months, 3 months, where, you know, that's the best way. It's the best analogy I have.
In 100 parts of the country.
Happening simultaneously in 100 cities. Yeah, I mean, I think that's where we're possibly headed, unless the flattening of the curve, things are happening. And finally, you know, some of these governors are taking this seriously and finally putting the mandates in. I mean, just blows my mind that in some cases this isn't happening. And even watching, you know, some of the videos that I see of people walking around and in parks and things like that, it's just people aren't taking it seriously. The other thing to remember is this is a respiratory pandemic. You need ventilators. You need potentially critical care to move these patients. And if you're going to end up doing load balancing, we're doing the number of load balancing trips on top of our 911 call volume. Our 911 call volume is through the roof, but then these load balancing situations are through the roof as well. These hospitals have been mandated to double their capacity by the governor. And so in order to do that and to keep, you know, to keep up with the demand, we're having to load balance and move a lot of people around, move certain groups out of hospital so that we can just have ICU, basically almost an entire hospital that's purely an ICU hospital. And so in order to accomplish that, we have to decompress and we have to move. So there's a tremendous volume on that, is just unbelievably through the roof. We've had a couple of local partners that have just done an amazing job for us in helping us out. But when we've reached outside of our region, basically, you know, it's not available because people are either busy or they just don't have the ability, you know, to respond.
What do
You know,
what do you mean by local partners?
so
Other
the
services?
private ambulance
Got it.
companies have really stepped up. I'll call them out. You know, ambulance is one, and senior care is another. You know, that have really stepped up, especially before the FEMA assets got here. Now that the FEMA assets are here, you know, we're using those as well as those from the commercial providers, and you know, it's been a really good group. I also have to call out Westchester EMS, or WEMS. They're up in Westchester, obviously hard hit, very, very busy. And they've also been able to, they activated their SOD teams, and they've been actually able to come in with ventilators on a couple of ambulances and help us move some of these vent patients. So,
What about vents? Vents is important to me. Do your ALS ambulances all have vents?
yeah, so we went to this a long time ago. Probably one of the first in the country, maybe. I don't know. I would assume this, but we have a ventilator on every ambulance. First off, we're an all ALS fleet, so we're one medic, one EMT.
Right.
Not inside the city of New York. This is in our core business, and every single one of those ambulances carries IV pumps, and every single one of those ambulances carries vents, and every one of our medics is trained to a higher level to be able to use those vents and pumps. And then we also have critical care trained paramedics as well. And then on top of that, we also have air medical with a helicopter with a critical care paramedic and a critical care nurse.
So do you think systems are going to finally learn that after this, their ambulances should be vent ambulances?
I hope so. The bottom line is, though, in order to buy those vents, we have to have financial support.
Like every disaster that I've ever been involved with, you can capitalize on it. Once we get the government to realize that we should have had vents on ambulances that we could even divert to some of the hospitals, I think that there'll be some funding for it. At least I'm making a push today with some congressmen about putting funding in for it, as I'm sure an AMT and others are doing. They've been encouraging me, and I really think it's the way to go. I mean, a bag mask is wonderful as a stopgap measure, but it's really primitive equipment compared to what we should be doing with a vent. You agree with that?
Right. And some, absolutely. I mean, some of these patients, to basically put them on a bag, or to bag them for the amount of time it takes, especially for these very long transports, because we're having to go, much farther distances than we would, is not clinically acceptable. Because they have certain settings, pressure settings and things like that they have to maintain. These patients are often in the prone position, for various reasons. I don't know the clinical aspects of that. Maybe one of your other calls or one of your other podcasts, you can talk to somebody clinically more about this and why that is. But you need to have the ventilators to be able to move these patients. And if you don't, you need to figure, obviously that's going to be tough now with supply and demand where it is. Yeah, and you may have no other alternative but to use a bag valve mask. But these are things, as a leader, you need to definitely be thinking about. The doubling of test times is another huge thing. Basically take your resources and think of like cutting it in half in terms of the availability to respond, right? Because if your ambulances are taking twice as long to be able for the next call, that means your capacity is going to be to respond is going to be heavily impacted. So that's something that.
Can you tell me what model vent you use?
I believe it's an HT. You caught me off guard on that one. I think it's an HT, a bird, or an HT vent. I'm not that close to it, AJ. I'm sorry. I can find out for you. I'm a little far removed from that level of detail, which is a little embarrassing. I apologize, but I know that we have ICU class vents on every ambulance at this point. So, we use them every day before the pandemic, and obviously we're using them all the time now.
My message is at this time to capitalize. I've never had a situation like this where I couldn't capitalize on it. I've been working with some people in the White House and other places to get Weinman, for example. They've had a log jam in the FDA for their transport vents. And I think it's going to happen. There's a place in Southern California that wants 1,000. They can get 500 of them right away, but they want to commit to 1,000. So if you think that there's something locked up by red tape, get to your congressman, let them know what the issue is, because they are loving this right now to be able to open up the red tape. I know everybody's critical of the government, but really FEMA and everybody's trying to get along. The one I understand that's really in a logjam right now is OSHA. There was a bill proposed in OSHA that would make mandatory masks and other things for EMS workers, and that bill was pulled back. So I don't know where that's at, but we're going to try and get that up as well.
Yeah, I mean, that's important, and I'm going to have a call to action for you here that I want to go over as well. But very quickly, a few more things in terms of tips for people. Remember, this is a marathon, not a sprint. You've got to take care of yourself personally, especially the leadership. You can't be there 24/7, 365. This takes its toll physically, it takes its toll mentally, and it's on everybody, obviously, not just the leadership staff, but the frontline staff. But oftentimes the leadership staff doesn't get time off, where hopefully at least our field providers do. So that can be very trying and taking on you. And quite honestly, you need to start to shift into a command staff burden share, so that we've moved to like 12-hour shifts for our middle leadership. Uh, so that we have somebody on 7 days a week, or seven now from a management point, not just supervisors, but a mid-level management level. We debrief every day twice. It's something we were doing well before the pandemic, about resources situation, what's the volume, what are the trends, what's the impact to the workforce, employee health issues, safety issues, questions, demand, monitoring the demand and anticipating and adjusting resources, adding resources. All of that's something we talk about twice a day in our system. The weather, all these things you have to really think about. And I guess we'll close with this, AJ. Again, is it's kind of this call to action, and I don't like this term. I don't like to use this term, but it's true. You just kind of said it, which is no crisis should go unleveraged. And to your point, and that's I believe everyone listening to this podcast it needs a call to action. You need to contact CMS. You need to contact CMMI. You need to contact your senator. You need to contact your congressman, both at the state and at the federal level, and get them to launch ET3 immediately with everything, without the administrative burden. Because if you look at the administrative burden of ET3, it's unbelievable. And they've delayed it at this point until November, which is fine. I mean, the demonstration project itself, but the tenets of ET3, which is alternative destinations, which you've already done. Thank you to those that helped make that happen. We don't have treat in place yet. We need treat in place. And we need the nurse call 911 triage support, as well as long-term financing of that. We need I believe that they should reimburse us without the 911 call requirement for some of these things, because at this point, we've got private and commercial providers who could be helping to perform services in the home in addition to the 911. The 911 system's burdened. I mean, how are they going to be doing services in the home? And so we need that type of thing. And same thing for the 911 requirement on the medical communications centers. And then finally, I think you've said it best, AJ, is we need permanent funding in EMS to make us sustainable, and then obviously make us an essential service. We're obviously taking 100% of the lion's share of the pre-hospital clinical work on this. Our people need pay parity. Our people need, all the things we've been trying to get for forever and a day. With this, and we need the right safety tools, we need the right clinical care tools, and our people need to make living wages, and and have parity with their public safety counterparts. So I think we've got to get those messages out. I know NAEMT ran a campaign where we had, I think it was close to 15,000 people write letters, which is unprecedented in the history of EMS. I believe that many people coming together, at least for NAEMT, and there's going to be a fourth campaign coming out, I believe. So please stay close to your emails and watch for that, or watch the NAEMT website. I believe there's an advocacy page there where they'll now announce the campaign. But in the meantime, before the campaign comes, pick up the phone, make the phone call, send an email. There's email addresses for all these people. You can go on to cms.gov. There's actually and type in ET3. You'll see there's an ET3 emails address. You'll see who the program directors are. There's a directory for who runs these programs, where you can get their contact information for emails and things like that. They need to hear us. They are collecting information. I actually sent a letter a few days ago, and they're keeping a spreadsheet and a kind of a letter on what people are asking for in terms of needing help and regulatory waivers and support on as part of ET3. And so if they hear from all of us, I think, especially with these things we're asking for, then hopefully we'll be heard.
Yeah, and there's a couple of things I want to add, because you have to really think outside the box. And obviously NAMT has to be our national leader to be able to try and get the unified voice heard, but there's a lot of backdoor approaches. My wife is a chief officer with a large community clinic system, and she got a call directly from the congressman's office saying, hey, we need to know for the bill, what do we need? And she called me and said, what do you need? And I said, EMS needs to be able to transport places like you and other places. And they pushed that to the congressman, and he pushed it back up the hill, and some things began to happen. So there's a lot of things happening, and don't be afraid to ask for money. Right now, there's industries, there's businesses that want to help out. Google, if they were in your area, would help out. Find out who your big industries are and call them and ask them to feed your troops. My wife has to feed 225 people every Friday as an incentive for them for their working, and that costs her $800. And she put an appeal out to her board and others, and fire departments are calling up saying, we'll give you $800. So this
Wow,
Friday they
that's
all
great.
get pizza. Last Friday they all got individual sandwiches, and that really means a lot to the troops. So don't be afraid to look around. N95 masks, anything, any of your industries right now, will try and help you out. And then on top of that, you have to support your local restaurants and other places. Just imagine going to a place in my little community and saying, I want $800 worth of pizzas, what that does for their economy. So John, thank you so
Yeah,
much.
no,
I mean,
absolutely.
you're a leader, you're a friend. We'll do this again. Get some sleep, because you look like you can use it. And we're all feeling the
Yes.
same thing. We're all cooped up. And some people like you cannot be cooped up. So you got to be careful. All our comorbidity factors, buddy, we got to be careful. So,
I know my wife's on me, and my boss is on me, and my staff is on me. But it's one of those things. I feel horribly guilty, when I'm not there. So even when I'm working from home and supporting them, if I'm not there, I feel like there's this huge void in my heart. But they're 100% supportive with my comorbidity issues, and I've been very grateful to them. And thankful for them that I have the privilege to be an honor to be working with them, and also be able to work remotely from home on occasion. So thank you.
yeah,
And
and I appreciate what you're doing for your staff. You pay attention to them. I know you pay attention to their stress. My understanding is that 911 centers are getting overloaded with suicides and other things at this point in time, and I think that's even going to get worse. So be real careful about it. Domestic violence has skyrocketed because domestic partners are being forced to stay together. So there's so many things. You just have to just read the paper
yes,
every morning
yep,
just to find out things you need to change in your EMS system. So from the bottom of my heart, thank you very much. From all of our viewers, I thank you very much. And I'm going to have another episode with Jeff Goodlow on ventilators that they're using in Tulsa and Oklahoma City. And
great.
that's really what this new EMS Today show is all about. So thank you very much. Stay safe. We'll see you again.
Thanks, AJ. You be safe and be well. God bless.